It's 9 o'clock. There's no timer there. Okay, the topic what I've been assigned, I will try. The topic what has been assigned to me is insights into temporomandibular joint replacement. When we speak about temporomandibular joint replacements, two things are of very important aspects what you need to consider. I consider TMJ replacement as a holy grail to the maxillofacial surgeon because we have thrown all our hammers through various incisions, balancing acts of arthroscopy and arthrocentesis, and finally we have zeroed down to doing TJRs or total joint replacements for patients who present to us with a varied kind of conditions which includes ankylosis or end-stage TMJ disorders. That's where your TJRs come into play. Recurrent ankylosis, fibrous ankylosis, whatever you take it as, or bony ankylosis, if the patient has a tendency for heterotropic bone formation, a good answer for these is your total joint replacements. When you speak about TJRs, three companies which came into action, I think Andy would agree with me. Yesteryears, Kent Whitek Christensen, and today you look at it, it's TMJ Concepts and Biomet prosthesis which are in the market. That's your Kent Whitek prosthesis which lost out on the race because of faulty designs which were designed on cadaveric studies. And today what we use is TMJ Concepts. TMJ Concepts, the biggest advantage of TMJ Concepts being that they have a titanium backed fossa component. And this is what I use on a regular basis. These are stock joints on the left of your screen and custom made joints on the right of your screen. Custom or stock, each one has its own advantage. Remember, stock joints are make to fit, whereas custom is made to fit. Is that clear? It's made for that particular patient, whereas stock is available on the shelf. You can ask for a stock joint. You don't have to order for it. This is a small classification what I've gathered to understand where TJRs have a role to play. If you want, you can please take in your photographs or snaps or whatever you want to. I've classified them into organic and functional disorders, and that's the area where your TJRs are here to stay. Neoplasia is one area where we have tried to do TJRs. It's still in its phases of inception, but not with a definitive answer. Whereas for me, the biggest take in this particular slide is degenerative joint diseases, a stage 4 Wilkes or a Dimitrolis stage 5. The goals of TMJ reconstruction is to reduce the suffering, contain excessive treatment costs, and prevent morbidity. Now, coming down to the indications, I'm not going to run through all this. It's for you to see. For me, the most important thing would be a recurrent ankylosis or polyarticular inflammatory disorders. Contraindications, allergy to the prosthetic material. When we speak about allergies, there is no single test to say that yes, you can test a patient for allergy. There are two leading questions when you have a patient coming in for a TMJ replacement. You can't get a lymphocyte transformation test done in your practice because these tests are not available across India. The simplest of questions you can ask the patient is, are you allergic to gold or platinum? Or if you have an orthopedic unit which is very well established, you can get your cast alloys, that's chromium, cobalt and molybdenum, for an allergic testing to see if there's any kind of allergic dermatitis. But even that is hard to say. Bruce McIntosh bugled his success with the use of autogenous tissues. I think we were from the school where they spoke and banged into us saying costochondral grafts are here to stay, especially in the pediatric population. If you ask me today, I have a 7-year-old baby who's come with recurrent ankylosis, operated 7 times with all modalities including distraction osteogenesis. What would be your take? Child operated 7 times with all modalities and he's in his 8th year of age. I would straight away go in for a TJR or a joint replacement. It is controversial. What happens to the joint when the child grows? That's the question which needs to be answered, but that's another concept by itself. But to bugle Macintosh's success, Lou Mercury came up with his take on use of alloplastic prosthesis, and I'm sure Andy would agree with me. These are the guidelines which were laid down by the British Association in terms of indications and contraindications for use of temporomandibular joint prosthesis. This is again the reformatted version of Lou Mercury and Peter Quinn. And the most important of the indications here is a dietary score of less than 5 out of 10, which is a proper indication for a TJR, a restricted mouth opening, which is anything less than 35 millimeters, excessive condylar resorption. Today, if you ask me, has TJR got a role to play in orthognathic surgery or dentofacial deformity? I would say yes, because most of the times patients who come to us with TMJ ankylosis have a retruded mandible, a micrognathia, a microgenia, and a bird face deformity. Previously they would say let's do a 2-stage surgery, but today what we do is a single-stage surgery where we plan to do a counterclockwise rotation of the maxillomandibular complex, where the entire mandible is coming down at the vertical ramus area by 20 millimeters, and at the level of the pogonium it's coming to around 30. So you're looking anywhere between 35 millimeters of mandibular advancement. When I say this, I take it with a pinch of salt. In my practice over a period of 20 years, done more than 100 joints, I was speaking to Andy, it's only time which will tell me whether I've done justice to the patient. It's too early to say that TJR is a success, because the shelf life for a TJR, according to Zimmer Biomet, is 20 years. And believe me, these are US FDA approved and CE certified. Are we looking at every molecule of the joint which is taken into consideration? How far is it pure titanium? That's T16Al4V. Are we looking at alloys of titanium which are incorporated into the TJR? We as a country, do we have a prosthesis which is purely titanium, or are we adding alloys which will have a failure in 20 years or in 2 years? I've seen more failures in TJRs in my career. When I started off in possibly 2013, I've seen fractures of joints, I've seen infections, allergic dermatitis, patients coming back with severe pain, a first bite syndrome. All these, it's only time which is going to tell us. Now this is a classification or telling us which is better, whether a custom or a stock. And when you do a stock joint, yes.
So what is first bite syndrome?
First bite syndrome is something, it is not to do with TM joint replacement itself. It's to do with any kind of TMJ surgery. When you transect through the neural network, there are collaterals which are developing over a period of time, the postganglionic fibers. So when the patient has the first bite, she complains of severe lancinating kind of pain, which is very difficult to control. I never understood this concept. When we did our first TJR, I would call the patient to clean up on the OPD. The patient was sitting on the chair, jumped out of the chair, and on the ground was crying with pain. So I went back to literature and I found this first bite syndrome. It would settle down over a period of time. It's like transecting the auriculotemporal nerve and you getting a Fraisse syndrome. Similar concept. Any parotid gland surgeries, any kind of parotid, any TMJ surgery, believe me, whatever concepts we speak today, whether it is TMJ approaches, has to be dealt with a pinch of salt, because you will have complications. But these complications are to be dealt. If you don't have complications, you are not operating. If you have complications, you are a surgeon. Otherwise, you become a surgeon orally. Orally oral surgeon. Okay, now the most essential component. Let me teach you give me 2 minutes extra. You have taken 15 minutes. These are conventional stock joints which are produced by Zimmer Biomet. These are available in sizes of 45 and 50. Now for an Indian mandible, suppose you plan to do a case tomorrow after Gyan, and if it's a case for a stock replacement, how do you decide whether my patient requires a stock or a custom? Very simple. You see this particular patient, the anatomy of the ramus on the right to the left is totally different. You see the anatomy on the right side, there is going to be a deviation of the mandible or the ramus outwardly. Can you see that outward pouching of the condylar head there? Yes. Whereas you see the right side, it's in line. So how do you establish this? All you have to do is take a PA view mandible, drop a perpendicular on the ramus of the mandible. If I were you, I would have taken a picture of this line. Drop a line at the skull base and to the vertical ramus. If this line is falling in straight areas where your ramus is getting aligned with the glenoid fossa, automatically this patient is an ideal candidate for a stock prosthesis. Suppose there is a deviation and the line is not falling into the ramus, he is a custom joint patient. You also have to look into the fossa canting. Remember, whatever we speak in TMJ replacements has to do with your facial deformity. In orthognathic surgery, if you go back in time, three things which our professors taught us was roll, pitch and yaw. Do you remember that concept which came from the aviation industry? This roll, pitch and yaw is something you have to look into even in the skull base, which is often not taken into consideration. If you're putting in a stock joint and if you have the fossa component sitting in the skull base and it is free floating there, because the skull base is deep and you didn't recognize it on the X-ray, anything which is mobile in the oral cavity or anywhere in the facial region is asking for trouble. So you need to understand if the skull base is deep so that you can graft the skull base. These are extreme maneuvers what I'm speaking about. But from a planning point of view, this is what you have to do. Is that clear? This is what I was speaking about. You need to understand the fossa, pitch and the roll and the yaw so that you keep it parallel to the Frankfurt's horizontal plane or the mandibular plane and then plan for your TJRs. And this is an STL model what I picked up when I did my fellowship in Children's Hospital, Toronto. See this particular patient, the same thing what I have spoken about, the vertical ramus on the right side is in line, whereas the left side has an outwardly differentiated movement of the condylar head. So the same patient is going to have a stock on one side and a custom on the other side. Now this is just for explanatory purposes. If I have a patient like this, I would settle for a custom joint prosthesis rather than a stock.
Sir?
Yes, madam.
Yes. How do you decide the fossa, the previous slides? How do you decide that fossa angle? How much it should be ideally and what is the variation possible, sir?
How do you decide how much is the fossa? How do you decide what angulation? Suppose the fossa is there. Suppose it's a patient with end-stage TMJ disorder. You always design the fossa keeping it parallel to the Frankfurt's horizontal plane. If you look at the literature from the European group published 2025, they say the distance, I think one of your PGs came and asked me this question, the distance what you have to maintain for the fossa or the ultramolecular high weight polyethylene is 0.9 millimeters from the external auditory cartilage, and the fossa needs to be kept parallel to the Frankfurt's horizontal. This is in non-syndromic patients. When I and Pramod operated a patient for Lauritsen type 2, Andy, you would agree with me, a Lauritsen type 2 patient where there is a zygomatic arch missing, or a Puzansky, the latest classification. I'm talking about Lauritsen centuries ago. If you speak about a Puzansky's type 2 or a type 3 or hemifacial microsomia, where your arch is missing, rudimentary arch, how do you decide where you want to put the fossa? That's where you plan the fossa, mirroring the opposite side, and where do you take the anchorage from? You take your anchorage from the mastoid region. That's called the mastoid anchorage. This is another extreme of planning for syndromic kind of patients. You take a mastoid anchorage, where the fossa is going to be much bigger. Now this is a bird's view from the inner side. I'm sure you will be able to appreciate. You see the angulation of the fossa or the ramal component on the left side and the straight component on the other side. Another thing what you need to look after when you're planning your TJRs is to look for pneumatization of the zygomatic arch. If your arches are pneumatized, please remember you need to look at, keeping it very simple, look at voids in the zygomatic arch. If there are air-filled cavities within the zygomatic arch and you have not done your preoperative workup, your screws are going to float in the zygomatic arch and it's going to go loose. So this is one component what you need to understand. Another technical tip what I would love to tell you is when you're planning your TJRs, your ramal component has to be parallel to the posterior vertical border. Why? Because if you angulate it and place it a little anterior, Lakshmi spoke about the size of the adult condyle, anterior-posterior and mediolateral. So if you place your ramal component a little anterior within the fossa, the patient's mouth opening or the translatory capacity is lost. Instead of getting a full 30 millimeters, you're going to get only a 10 or a 15. So the more posteriorly you place your foot plate, better is the mouth opening. When I say more posterior, it's as posterior as possible, which is shown in this. And conventionally, remember, the joints what we have been using across India are from various companies. But today there is a resurrection from a company from the clinics of North America. If you go back, what we studied then as postgraduates was called as the Hoffman-Papas device. And am I right? It's the Hoffman's-Papas device which came into play those years with the Kent Vitek or the Christensen's device. Today, there are companies where the condylar head is not wide anterior-posterior, but it is wide mediolateral. The condyle is barrel-shaped because they claim to have a translatory as well as rotationary movements happening within the joint for the patient. If you go back to literature where Maurice Momartz from the European school says he tries to suture the muscles, that's a lateral pterygoid, to an aperture which is created within the joint so that the patient has lateral excursion and protrusion movements. I really don't know how that happens, but this is from a surgical point of view.
I think I know how that happens. I think the reason why he can do it is that most of them don't do ankylosis cases. Most of them do the ID cases. So when you are removing the condyle for an ID case, you know this is the lateral pterygoid and you can pass a suture through that and keep it separate.
What she means to say is, we are more aggressive a surgeon. No, let me finish. From an Indian scenario, we have more of patients whom we treat with end-stage and ankylosis kind of patients.
We have more ankylosis.
Yes, whereas the others from the Westerners, theirs is more related to degenerative joint diseases.
Degenerative joint disease, arthritis, wherein you know that your condyle is still there, so your attachment to the lateral pterygoid is still there. So when you remove that, you know, okay, this is the lateral pterygoid, we pass a suture and keep it there. In an ankylosis case, pura इतना सारा कचरा होगा, you will never know where the lateral pterygoid is. That is right.
Okay, when you plan for a TJR, the essential workup for you here is a modified lymphocyte transformation test or a LTT and a leukocyte migration inhibitory test. Now whether this is available in your practice, I really don't know. I have not seen any labs do this. So the simplest thing for me would be a patch testing or a topical skin or a subcutaneous testing. And that's the article which speaks about using the different kinds of alloys. That's your chromium, cobalt and molybdenum. When we speak about custom-made TJRs, these are the indications. Where does a custom-made TJR have a role to play? When you have a simultaneous maxillomandibular advancement to be done, you need to understand that these are massive advancements. And when we do these kind of advancements, these kind of surgeries, we have gone through a lot of complications, but complications are a part and parcel that shouldn't be a deterrent to your surgical practice. These are few case scenarios. Role of TJRs in trauma. A patient with condylar fracture managed conservatively, went into TJR, went into ankylosis. And this is how I do my FAT, what I picked up from George Dimitrovich, where Sonal spoke about periumbilical fat harvesting. For me, what works as the simplest maneuver is to place an incision say possibly 3 centimeters from the umbilicus coming down to the subcutaneous, harvesting fat there. Now the question is, when you're doing your TJR, how much of fat are you harvesting after the joint replacement and why? Your fat being harvested for a TJR is basically to prevent a heterotropic bone formation. How much do you pack? Is fat going to cause an infection there? The easiest way to understand that I need to pack so much amount of fat is arbitrary. So what do you do? Once you've done your TJR, all you have to do is irrigate that area with whatever 2 ml or 3 ml syringe of saline and prevent that saline from falling out within that cavity. If that cavity where you've done the TJR holds 3 ml of liquid there, it's 3 ml of fat what is to be placed at the neck or the stem of the joint. Is that clear? That's how you determine as to how much fat I need to put in. And this is a comparative analysis from Sanjay and Ajay, where they've spoken about success rates of alloplastic reconstruction. And this is one of the other articles, that whether there is a volumetric shrinkage of dermis fat versus buccal fat pad. And I'm sure dermis fat is here to stay rather than buccal fat pad, which has a more shearing tendency. This is again case of bilateral TMJ ankylosis. Those days, this was my first case what I did. A high submandibular or a periangular doesn't matter in these kind of cases. All you want to know is that the joint is sitting well, and that's his post-op. And these are many other kinds of cases where you do your TJRs, where there is bilateral TMJ ankylosis, and this patient came to us with severe ankylosis, part of the bony cranial flap removed there. I prefer to do more of an endoral kind of approach rather than an incision for TMJ replacements. The very reason being, remember two things. Sonal spoke about incision, whereas I am speaking about endoral, because my take on endoral approach, what we were taught, is that you are bear hugging the tragal cartilage. Remember, the more you stay closer to the tragal cartilage, lesser the chances of a nerve injury. And you have that window of 1 centimeter. You see the study by Miller et al., where you have a safe window of 1 centimeter. Within that 1 centimeter, you place your incision from the root of the arch to the temporalis fascia, a 45-degree approach, as Sonal spoke about, which was promoted by Ed Ellis. There's another approach where instead of placing the 45-degree incision at the temporalis fascia, you place a reverse L incision at the root of the arch. That's a horizontal incision within that 1 centimeter boundary at the level of the tragal cartilage. That's 1 centimeter. And then follow the tragal contour. So it becomes a reverse L. Can you see my fingers here? It becomes a reverse L or an inverted 7. With that, what is happening? You are raising a flap which you can use to cover the joint prosthesis after your surgical practice. So these are small modifications we do in our patients, and that's the fossa component sitting there. And she spoke about the periangular approach. Periangulars are of choice based on the type of situations you are encountering. Now my periangular here, I've taken it a little vertical so that my prosthesis is going to fit well. And there you see when you go submasseteric, you have a bloodless field there. And those are the cutting guides what we use to resect the ankylotic mass. And that's your left TMJ endoral approach, a very nice and versatile approach where you dissect below the subcutaneous plane. And remember, whatever the approach, whether it's preauricular, endoral or an incision, you divide your approach into two types. That is, one above the arch and the approach below the arch. So always do your approach above the arch first. When I say that, you identify the fascia first on the top. Once you have done that, stand at the head end of the patient and go in the precartilaginous plane, which is an avascular plane, and release your tissues. Believe me, you're going to see a fascia through the entire area, and then it becomes easy for you to get your incisions to go under the fascia and the nerve is transected or into the anterior flap. These are various approaches. There is the exposure to the joint prosthesis. and that's the masseteric epimycin. I use a small nerve stimulator which is available for 3,500 rupees from Medtronics, where you tell your anesthetist not to give any muscle relaxants. Use your nerve stimulators if you can, so that you are safer in your approach. That's your cutting guide in place. Remember, all TJRs to be done during your surgical practice. 3 things very important is to understand the cutting guides and the models which are given to you. Models are not to be staying on the trolley. When you're using these models, play with them on the OT table along with the patient so that you don't go wrong. You get only one chance to do a custom-made joint prosthesis. I've explanted more custom-made joint prosthesis because of wrong angulations. I'm not saying it is a fallacy. I'm saying what I want to tell you is everything is achievable, but it requires detailing and planning.
So, we are 11 minutes over.
How much?
11 over.
11. I still have another 8.
Over. I was 20 minutes over.
Okay, fine. So this patient had a midline osteotomy done to get his occlusion back. I did the midline osteotomy. Now there is another school of thought. Would you do intraoral procedures when you're doing your TJRs? A strong no. If you ask me today, would I do this? It's a disaster. But when I say that, I don't know whether my other colleagues, Pramod and Nehal, would agree with me. Contamination of intraoral versus extraoral, because you're looking at total different kind of bacteria which is there inside and outside. The major reason for a TJR prosthetic infection is not the infection at the ramal component, it's infection at the fossa component, because the fossa component is hydrophilic. All infections in the TJR happen at the fossa. Cutibacterium acne or P. acne is the main cause for these kind of patients. So when you plan for a TJR, the most important component what you need to use during scrubbing of the patient is your chlorhexidine gluconate. And if your patient has been operated multiple number of times in many centers, take your patient, take a nasal swab and see if he's MRSA positive. Get a decontamination protocol in place, get him decontaminated, and then plan for your TJRs. And this is on-table CM to understand the positioning of the prosthesis. And then that's the PA view. And these are extended joint process. I think this is the same kind of case what you had shown me. But the biggest component today is, would I do this? This is from Zimmer Biomet. Would I do this component today if I have a patient? I wouldn't do this. Why? Because without a bone flap, this is going to be a failure. I'll tell you why. Because all these components, this is made from Zimmer Biomet. I have a aperture which is given here. I'm sure you can see it from far. There's a small lip of metal given there. That lip of metal given there is for a reason. After you've done the TJR, with so much amount of weight on the TJR, it's going to sag down. To prevent a condylar sag, we use a 10 PDS suture and hitch it to the zygomatic arch. Today, would I do this? I would never do this today because it's all metal and it does not have a cradle kind of bear hug to have bone in it. Only metal without bone is going to lead to a fracture exactly at the junction of the angle where the horizontal meets the vertical. This is an area of concern when you have extended TMJ TJRs. An excellent paper in Journal of Oral and Maxillofacial Surgery 2023 edition. Pramod, Subhash and Arjun have written this paper where they've used free fibulas along with custom TJRs. Arjun, have you come across fractures after that?
So there is both, like you said. There is both. Yeah, so as you mentioned, if it is only metal, there is a high chance that the plate would fracture, especially at the angle. And the other issue is once you resect, there's a lot of soft tissue that has also been removed. So you haven't replaced soft tissue. So the possibility that the implant would get exposed intraorally is also high, and it may get infected. At the same time, since there's no bone, because of the torsional forces, there are chances that the plate may fracture also. So if you have bone inside, that is much better, because one, the plate has a vascular tissue and it will not open up, it will not get infected or exposed. Second thing is the load on the plate is much more reduced. So chances of plate fracture is minimal.
Thanks, Arjun. This is another case scenario. I'm going to end my talk. I don't want to take much of your time. Boy with conventional micrognathia, microgenia, severe obstructive sleep apnea, as I had spoken to Dr. Sahu yesterday. We work closely in conjunction with the pulmonologist. We get a PSG study for every patient today, a polysomnography. But do we end at a PSG? Today, if you ask me, polysomnography is a second adjunct. But today, any patient coming with TMJ ankylosis or any kind of restriction in mouth opening, PSG is good. But for a patient with end-stage internal derangement where there is progressive retrusion of the mandible in a clockwise direction, where the patient has lost the chin prominence, we would subject them to what is called as DICE, that is drug-induced sleep endoscopy, to understand where the problem is, whether it's at the naso, oro, or the hypopharynx. So this is another patient who came with TMJ ankylosis, severe form. Now, do I do a TJR on this? It's impossible to do a TJR in this because of the soft tissue which is redundant there. So what we planned for a distraction osteogenesis, and we did a simultaneous distraction osteogenesis using a multi-vector distractor. That's the deformity, a classical bird face. We did the distraction, and the only thing what we did differently was we maintained the distractors for an extended period of 1 year. Now, why did I keep it for 1 year? Is mainly to get the good consolidation period and good quality of bone, because there's no conflict of interest here. The Synthes distractors come with the carborundum rod, which helps us in consolidation. And that's post-distraction. Good anterior-posterior projection. And then we went into removing the distractor. That's the quality of bone. Once that was done, we planned for a simultaneous TJR because he wanted a posterior stop of the mandible post-resection. And I again did a simultaneous genioplasty as well. Would I do this today? I would never contaminate oral cavity to the external. You would always stage your surgeries and do the genioplasty as a secondary procedure. You don't want a contamination there. And these are many other patients who come with TJRs along with simultaneous orthognathic surgeries, wherein a lot of planning goes where you do a contralateral USSO. If you go back to the article by Edilis on the concept of unilateral sagittal split osteotomy and its relevance in total joint replacements, what is the anatomy involved? It's a very sound and stable procedure where you're increasing the length of the mandible on the affected side and you're doing a contralateral unilateral sagittal split osteotomy and correcting the cant, which is proportional to the amount of vertical movement of the mandible on the affected side. Those are patients with pre and post TJRs, and that's the occlusion which gets settled with your total joint replacements, and that's the increase in the ramal height post TJR. There are many other patients. I would love to stop my talk here. Any questions? I'm free to take any kind of questions, please. Thank you.
Later we have a discussion. Sankalp, we have time for discussion.
How much time will it take for people to come over to learn? PMJ सीखने के लिए कितना टाइम लगेगा?
PMJ सीखने के लिए?
PMJ सीखने के लिए कितना टाइम लगेगा? Is Arun's question.
Let me be honest. My PG was Sankalp. When I took over as the head of the department in Manipal, Sankalp was the first person to assist me for a TMJ surgery, a preauricular approach. I'm being very honest. Yes, as teachers, you need to teach your postgraduates, but the sad part is, the teachers are still learning. I'm being very blunt. How many of our teachers taught us? They tried their best, but today is an era where you need to decipher and give everything to a postgraduate who believes in us and comes to us. And him standing there is a proud moment for me because he is into TJRs, he is into TMJs. He put The first approach was with him was a pre-auricular way back 15 years ago. We did it together. And your question, how long would it take for me to learn TMJ? Spend just, if you want to do a good TMJ replacement, a good articular disc plication, all you need to do is get your anatomy right. 6 good cases, good teacher. That's all it is. It's a myth that we can't. We all can, provided there is some mentor who stands by you and teaches you.